this quiet one, boy, that all the fun has been denied. He left his kids on wild, the day fortnight and feels alone. So I sat on the stoop, looking for some clue about all he done, drinking at the Flamingo Club.
Ti butta giù, ti porta dove vuole, non ti fa capire, fa solo male. Hello, my dears. Hello,
Hello,
Emilio.
Hi, Jeffy.
Are you ready for the next episode?
Hello, Emilio.
Hello, JP.
Welcome to the Dermoscopy Excellence.
Digital training.
Let's start from the clinical.
Are you ready for the scalp? Some data highlighting a significantly worse survival for acral melanoma.
Here, again, you make the diagnosis because of the arborizing vessels sharply in focus. So, this is our destiny, my friends. If someone is connecting right now,
Yes.
then they are saying, okay, let's stop seeing this stupid course.
But then, if you look at the tables and you see the reason why.
Melanoma on the face is a lazy guy.
Morphologically, dermatoscopically.
Bravo, my president. Eh?
Ma che bello, che bello. Hello, my friends. Are you, do you hear my voice? Strong and clear?
Strong and clear.
Yes, because I have a brand new microphone for my webinars. Yes, I'm very proud.
Show us, show us.
I'm very proud of my new microphone. Look at this.
Ma che bello, ma che bello.
Che bello, guarda. Eh.
Orange.
What is Nita?
What is of course, if we start 3 minutes before our time.
Sebby,
We are perfect in time.
we are perfect in time. Don't blame on Sebby. Yeah, don't blame on Sebby.
No, we blame on you, Jeffy, not on Jeffy.
Of course. By the way,
Allora, ragazzi, this is a very nice episode, let me tell you. Very nice.
yeah,
Very
my
nice.
prediction is that the episode today will last 2 hours.
Yes.
Yes, I suppose so. So be prepared to go for dinner at 9 and instead of 8. But please, Sebby, go. Yes. Should we re-excise lesions diagnosed as severely dysplastic nevus? Yes, no, sometimes. Hello, Nisa. Ciao.
Hi. Sorry, I'm a bit late.
Ciao,
Ciao.
ciao, ciao, ciao.
By the way, guys, I don't know in Turkey and Italy, but here in Greece, it's really summertime.
Summertime, yeah.
Yeah.
Here.
Exactly the same,
Yeah.
unfortunately.
Unfortunately, exactly, because it will be a very long summertime.
Yeah.
Very long. Okay, so let's see how things are going with this. Yes. So 39% said yes. 24 said no. 37 said sometimes. So you see, it's a very intriguing topic. It's a very, let's say, doubtful situation. What should we do? So we will try to cover it, right? Emilio, what did you prepare for us?
Well, what I prepared is not related at all to the question that you asked.
Okay, Sebby, go.
Go.
Yes. So
Of course, the question that you asked is very interesting, and I don't know, in your cases, this is included, so we will have the chance to discuss it after you get it.
yes.
Okay, very, very, very good. So really, the content for today is, I mean, there's a lot to say.
Yes, not only in the realm of melanocytic tumors.
Oh, of course not. Of course not only. In fact, what I prepared is mainly related to non-melanoma skin cancers. But anyhow, there is a lot to discuss for sure. Let's keep the quotes and go to the paper of the week. But for today, I prepared the following. First, let's take a very quick look at things we know,
Okay.
but let's remember for a moment the basic stuff. So the basic stuff concerning margins for the three main tumors is the following. For melanoma, everything is clear, and I don't think we need to spend time here. The only thing maybe that deserves a comment is concerning the deep margins that we don't often discuss. We always discuss about the peripheral margins. So for the deep margins, this is of course from the NCCN guidelines. You can see that the recommendation is that for melanoma in situ, in fact, when the depth arrives at the subcutaneous fat, it might be already enough, so there is no need to go deep to the fascia. While for invasive melanoma, the general recommendation for the wide excision, of course, is to arrive until the fascia of the muscle. Okay, that's it for melanoma, and let's keep it because here the things are quite clear. What is much more interesting, in my view, and the guidelines are more problematic in terms of their consistency with real life, is in basal and squamous cell carcinoma. So in basal cell carcinoma, as you can see here, the recommended treatment for low-risk BCC is we have a series of options, quite different ones. So you see that the level of recommendation is the same for curettage and electrodissection or shave removal or standard excision with 4 millimeter clinical margins. And then another interesting thing is that in case you select the excision, then if your margins are negative, okay. If your margins are positive, you see here that the recommendation is to return back with Mohs surgery or ciliary excision or radiotherapy for surgical candidates. And this is definitely a topic that I would like to discuss with you a little bit in the following minutes. And for high-risk BCC, then we have a recommendation for either Mohs surgery or standard excision with wider surgical margins without definition of what this means, but this practically means until 10, maybe 6, 7, 8 millimeter until 10 surgical margins. And again, if the margins are negative or positive, we have to adjust our management accordingly. Obviously, where the margins are positive, the recommendation is that we do something more. So we resect, or at least we do radiotherapy. Finally, for squamous cell carcinoma, more or less same as it is for basal cell. So again, low risk and high risk. For low risk, again, a series of options, among them the standard excision with 4 to 6 millimeter margins. And if your surgical margins are positive, then again, Mohs or re-excision or radiotherapy. And for high risk SCC, very similar to what I just showed you for high risk BCC. So these are the guidelines. More or less, we know them. But in my view, for melanoma, okay, but for the other two tumors, there is a significant gap between what's written in the guidelines and what happens in the clinical practice. And I will show you immediately another paper, which we published about a year ago. This is not a study. This is just a report on the real life management of patients with basal cell carcinoma, individually treated patients with basal cell carcinoma. And then you can tell me if you think that your experience is quite similar or not. So,
Emilio, just a simple question. Why did you decide to publish this paper in another journal than DPC?
I don't remember.
It was rejected.
Don't have good answer. Now you caught me. Now you got me. Yeah, I apologize.
Are you a member of the IDS? Yeah, this is a very good question. Please respond. Yeah. In the
Please-
meanwhile, yeah.
Please respond yes. Yeah, 85%. We reach a good percentage. So this is what we did in the real life in cases of basal cell carcinomas that were excised, and then the report was positive margins. Okay, let's see what was the case. So of 1,700 excised basal cell carcinomas, in 84 we had involved margins. Okay, here you can see the characteristics of the tumor with positive margins. I just highlighted here that 24% were on the trunk, 20%, interestingly enough, were on the nose located. Okay? So 84. Of these 84, in the real life, we decided to re-excise only 26. In 40 cases, we decided to do nothing at all, just monitoring. And in 20 cases, 18 cases, we decided to do a non-surgical treatment, which is practically either imiquimod or cryo or combination of imiquimod and cryo. Okay, these were our medical decisions one by one in these individuals. So only in 26 we decided to re-excise. Here we try to analyze if there is something that is associated with our decision to re-excise or not. And practically, you see here, this is the strong association, 0.003, the location. So practically, it appears that in real life, we usually decided not to re-excise tumors located on the trunk, mainly, while on the face, we were more prone to re-excise. This is a difference that came out of the analysis. Interestingly enough, the subtype was not really affecting our choice in real life. And now comes the more interesting part. What happened with these patients that we treated in the way that we treated them? First of all, the ones that were re-excised, in 53% of them, in the re-excision, there was residual disease. In 46%, there was no residual disease. So 50-50.
Okay.
More or less 50-50. And now the most interesting question: what happened eventually with these patients with involved margins? Did they really recur clinically? Yes or not? Because this is the real question in my view. And the result is the following. If we see, first of all, the total of 84 patients with involved margins, eventually only 16.7% recurred clinically. The other 83.3% did not recur clinically. And if we go to the subgroups, you see that in the ones that we re-excised, 7.7 finally recurred clinically. In the ones that we did nothing, only 25% recurred clinically. And in the ones that we did imiquimod or cryo, only 10% recurred clinically. So in my view, that's interesting to summarize the clinical reality. And now you please tell me if you think that these numbers make sense also according to of course, maybe you did not calculate, but I mean, if they make sense to your clinical reality.
Yeah, it makes sense.
Yeah.
It makes sense.
Okay, so I also have a good number of cases that I have that follow in the presentation, but I don't know if maybe I do a break here and we or I continue. You think?
Just go ahead.
Okay, good. Let's see a couple of examples. So we start with this lady who has on her nose two different things. The one is on the tip of the nose that you can see. The clinical and dermoscopy. So what do you think it is? Keratoacanthoma, probably. Yeah.
Well
Yes,
differentiated.
CC or keratoacanthoma.
Okay, very good. So keratoacanthoma, which by the way was excised with a shave excision. And then on the lateral part of the nose, there is this obvious basal cell.
Infiltrative.
Yeah. In which what would be the management that you would select? Would you biopsy, would you excise it, or would you apply cryo or imiquimod?
Looks like
Excited.
Excision.
Excision, direct excision, because it's infiltrative. BCC.
This is what we did. Report BCC nodular and morpheaform, deep margin clear, lateral margin clear, distance from deep margin 2.5, distance from lateral margin 0.5. All
It's
good?
okay.
All
Good.
Yeah.
According to the guidelines, it's not good, but it's good, I think.
Yes. Okay. Agree. So that's what we thought. According to the guidelines, it's not good, but it's okay. All the margins are clear. It's okay. So in this case, we decided not to do anything else. But a few months ago, you see the recurrence of the basal cell carcinoma that was excised once again. And here you can see after the second excision. And a few months later, you can see a second recurrence of the basal cell carcinoma that was also excised, and eventually nothing terrible happened. But let's say that in the end, we had to do 3 operations, and the defect was quite big. So maybe in this particular case, the best idea, theoretically at least, would be to biopsy first, since we consider that it could be an aggressive subtype, and schedule a more sophisticated surgery like MOS or slow MOS in order to make sure that the margins will be okay. So, in general,
Emilio, for that case, for the previous case, I think it's also feasible to perform a radiotherapy, because the lady is an elderly female, right? So radiotherapy could be a good option there.
definitely. Yeah, but I mean, the management was feasible surgically, so it was not an issue. But let's say from a theoretical point of view, ideally, when we have aggressive BCC subtypes, maybe the best idea would be to biopsy, confirm that they are aggressive subtypes, and then schedule a more sophisticated surgery. So, in my view, what careful excision means would be either MOS surgery, if possible, if not, at least wider margins, if not, at least standard excision plus an adjuvant treatment, if not, at least standard excision and close follow-up, because we know that we are at quite high risk for recurrence, okay? Now, I will skip a few slides because we will spend a lot of time in them in order to reach this case. That's, as you can see, an obvious basal cell carcinoma located on the upper lip. What would you select to do? Excise, I guess.
Yeah.
Excise.
Very good. We excised it. Report was basal cell carcinoma, of course, nodular, of course, fully in line with what we see dermatoscopically. Deep margin clear, lateral margin involved. We re-excised, and it was one of these cases that I showed you earlier, that there was no residual tumor in the re-excision. And of course, I showed you this data earlier. So to conclude, I would say that for basal cell carcinoma, when margins are involved, in my understanding, we should behave, if possible, like this. If we have an aggressive subtype, then maybe the best idea would be not to ignore the fact that the margins are involved, because the chance of recurrence is really high. But if we have a non-aggressive subtype, then there are scenarios in which we can be more relaxed, especially when the lateral margin is involved and when the location is not extremely high risk. We can select either a watchful waiting or a non-surgical adjuvant treatment like imiquimod. Instead, when the deep margin is involved, or when the tumor is located, in our experience, particularly on the nose, then monitoring would be quite tough, and maybe the best option would be to re-excise. So that's, I would say, in this schematic is my conclusion on how ideally we should manage in the problem of involved margins for basal cell carcinoma. It's much different for squamous cell carcinoma.
Yes, exactly.
Much different, and this is in the next two cases that I have prepared. But let me stop for a moment here. Let's discuss these issues that.
Let's say this is a very good way to conclude about BCC. BCC is not an aggressive tumor in a great majority of cases. So why not wait and see for non-aggressive subtypes? So I agree completely. This is a very logical, let's say, way of doing. But for squamous cell carcinoma, it's much different. I mean, in squamous cell carcinoma, mostly we have to re-excise when the margins are involved.
Yeah. If we have time, I will show you later a couple more cases, and we will see that it's much different.
No question about it. Yeah. Let me see. There are no questions for the moment.
Well, there are some
Yes, they're on the chat.
So please put your questions in the question and answer box.
So Alexander asks, for this BCC on the nose, Emilios, why not MOS rather than direct excision?
Yeah, that's what I said as a conclusion of this case, that ideally what we did was not the perfect choice. The perfect choice for a tumor that appears to be aggressive already from the dermatoscopic point of view, aggressive meaning infiltrative or morpheoform, then the best option, at least theoretically, would be to schedule a careful surgery or a MOS surgery, ideally, if it's possible. Then,
but I think that an important point is that in Greece, as well as in Italy, as in many countries in Europe, most surgery is not as widespread or available as it is in the US or Australia or the UK. We don't have it available, is the answer.
I agree completely. I agree completely. It's very difficult to find a MOS surgeon in our countries. By the way, concerning Pino's question, so location on the nose and deep margins involved, and or. So one is enough to decide to re-excise.
Yes, and or. Yeah.
Was there a subtype analysis on BCC recurrence, type H, other risk factors, vitamin D levels?
Vitamin D levels, no.
Oh.
By the way, I don't know what you were thinking, Alexander, and asking about vitamin D levels. Do you think that they could be related with a risk of recurrence? Interesting. Concerning the other parameters, the only parameter that would significantly increase the possibility of recurrence was location on the nose. But of course, that's a relatively small series of 100 patients. That could be, if the sample was 1,000, then maybe a few additional parameters would come up as important.
He's asking a very important question, which is actually the reason for having this episode. How much should be the distance from tumor in pathology report? Not clinical, histopathology. Is it important or clear margin is okay?
Clear margin is okay. This is, let's say, the point is this. We have to understand that this is an important question, and the clear answer is clear margin is enough, because this is what most surgery is doing. Reducing the amount of tissue that you have to remove in order to get clear margins.
Of course, the difference is that in most surgery, you have a real examination of the entire margin, while
you have horizontal. This is the big difference. You have horizontal sectioning versus vertical.
Exactly, but conceptually, we have to make sure that we excise the BCC, squamous cell carcinoma, or the BCC entirely. So even if it's 1 millimeter, theoretically is enough.
Yeah. Very sporadic in UK2, not enough surgeons performing MOS. Yeah. Okay, it's not only a matter of available surgeons, because we do have this opportunity in our hospital, but you also have to take into consideration the costs in time. I mean, most surgery equals to 3 or 4 conventional surgeries in terms of time. Therefore, this could increase exponentially the waiting lists, which are already quite heavy. So we have to be selective, obviously.
Yeah. Can dermoscopy help in differentiate subtypes of BCC?
Of course.
Yes. Let's say we have some data, but we have to study more. In my view, it's important this is an important topic to still try to address adequately. What to do with lentigo malignant melanoma with 2 millimeter pathology on one margin on the face, re-excise? No, 2 millimeter. Well, for melanoma, it's different. For melanoma, it's different.
It's T1A, which means invasive melanoma.
Which means invasive. So it's different in melanoma. It means that we have to ask the clinician, the surgeon, what was the clinical margin he decided to take in order to excise this lesion. If the margin was the ones we expect for an early invasive melanoma, so 1 centimeter, then theoretically is enough. You know what I mean? Theoretically is enough. But if the clinical margins, which we decided to use for excising this early invasive melanoma, is 2 millimeter, then of course we have to re-excise. Yeah.
In Morphe for BCC or SCC with poorly defined margins, surgery and delayed reconstruction can be a valid option, of course, yes. Dermal substitutes can be used to avoid retraction, absolutely, yes. Low vitamin D levels are often associated with poor prognosis in other conditions like melanoma, COVID, yes. I know that there are some data about it, but I cannot guess how it could be associated with the risk of recurrence of a BCC, but I don't know, of course. Why pathologists underline the millimeter of distance instead to write clear margins?
Well, it means that they give you more information. It's good. It's good. It's good. They are more precise. Yeah. Yeah. By the way, I mean, this is only part of the job we have to do today. This is only part, because I'm going to show you the other part of the job we have to do today, which is not only related to the margins of BCC and squamous cell carcinoma, but also trying to speak a little bit about the issue of the re-excision stuff concerning melanocytic tumors. In my view, this case underlines very significantly, very clearly, the reason why we do all these re-excisions of melanoma in situ, early invasive, thick melanoma, and so on, yeah, in order to prevent local relapse. This is a lesion that was excised a few years ago, and it's, as you can see here, relapsing, yeah? And as you can see here, this is a clear-cut melanoma. And of course, relapsing after a few years outside the scar, but attached to the scar, it means that most probably this is the local recurrence of a previously excised melanoma. By the way, why this lesion was excised? Because this lesion was not re-excised. 2 years before, when the lesion was excised for the first time, this lesion was diagnosed as dysplastic nevus. Therefore, the lesion was not re-excised, right? And this is the reason why, probably, this is the reason why this melanoma was recurring after 2 years. And by the way, now it's a melanoma 0.9. It's not a completely an early one, okay? So here we have two main differential diagnoses with which we have to confront and we have to decide what to do, yeah, concerning the re-excision issue. The first differential diagnosis is dysplastic nevus versus melanoma in situ, and the second differential is Spitz versus melanoma. Okay, Spitz nevus versus melanoma. Okay, and I give you already my conclusion. The conclusion is that whenever we have this differential diagnosis, this problem in front of us, the decision should be made case by case. Punto. Case by case. Okay? And now I give you a few examples, and you have to help me to decide what to do. Okay? So this is a 19-year-old girl. This is a lesion located on the back. Clinically, I would say this is a congenital nevus, small
Yes.
genital nevus. Dermoscopically, the lesion is the picture is a little bit blurred, but you can understand why the lesion was decided to be excised, because it was a funny-looking lesion. There are some globules, as you can see here, 6 p.m., which, I mean, it's a strangely looking lesion. The lesion was excised, and the diagnosis was SAMPUS, superficial atypical melanocytic proliferation of uncertain significance. Fortunately, nowadays nobody is using this formula anymore. You will see that there will be more and more diagnosis of melanocytoma. Whenever we don't know what it is, but histopathologically, we will use more and more the term, the pathologists will use more and more the term melanocytoma. Anyway, so we have in front of us a lesion which is difficult to assess by the pathologist. So he's telling us, I'm not sure if this is a benign nevus or a melanoma. Okay? Now we have to decide, what should we do? Should we re-excise this lesion? Emilio, what do you like to do?
In general, I am optimistic about this lesion, mainly because of the age.
Exactly.
So I feel quite relaxed.
Yeah.
There is something, of course, which is inconsistent. The fact that the lesion appeared to be clinically and dermatoscopically not completely superficial. It was rather like, I mean, a compound nevus.
Okay.
While in the report, SAMPUS usually refers to junctional lesions, so superficial, the ones that are flat. That's a little bit annoying in this report.
Yeah.
So, I mean, maybe I would like to discuss with the pathologist a little bit this controversy, but in general, I am optimistic with this case. I believe it's benign.
Exactly. So the point is this. This can only be decided case by case. There is no rule telling us what to do in a case, in a situation like this. Okay. So taking into consideration that this is a 19-year-old girl, and probably this is just a funny looking congenital nevus, we could easily decide not to do anything anymore, just follow up. Okay. But if you tell me, well, in order to be more on the safe side for the patient, for the parents, and so on, why not making a little re-excision of 5 millimeter? And I would find also this decision reasonable. You know what I mean? So there is no rule how to decide in this particular context. Okay.
By the way, Alexander says something very interesting in the chat. Which is, he says, I would let the patient decide. A bigger scar if she wants more peace of mind. So the concept of sharing the decision with the patient is very important, especially in scenarios like this in which there is not a clear-cut choice. So that's very important. Of course, it does not work always, because many patients turn the question immediately to you, saying that I will do whatever you tell me. You are the doctor. You decide.
But if you are in my position, what would you like to do?
If it was your daughter, what would you do?
If it was your daughter, and so on and so on and so on. But trying to do a shared decision making is a very good idea overall in many scenarios.
Okay, let me show you another case in which, in my view, the situation is a little bit clearer. So we should maybe be more in agreement what to do. This is a young man, 30 years of age, and this is a lesion located on the shoulder. And this is what you can see morphologically in dermoscopy. It's a mainly reticular lesion with a extensive area of regression in the center. And again, the diagnosis is a little bit in the middle, severely dysplastic nevus. Okay. So now, taking everything in consideration, would you like to re-excise or yes or no? I don't know.
Re-excise.
Here it's
So-
different.
Okay, so Nisa says re-excise. Constantino?
Re-excise.
I say, what were the margins histopathologically?
2 millimeter.
2.
No,
2.
no. Yeah, so it was a clear. It was clear margins with 2 millimeter.
I'm okay.
You okay? Okay. You say re-excise. You say okay, Emilio.
Yeah, okay. I am in the middle. So I strongly believe that this is a melanoma in situ. I'm fully convinced
too.
that it's a melanoma in situ, although it belongs to a 30-year-old guy with many nevi. However, this is too much from a morphologic point of view. It's a melanoma for sure.
Yeah.
And now the question is if I am okay with 2 millimeter margins for a melanoma in situ. And in this question, I would say officially no, officially re-excise. Unofficially, I don't think that this is so important.
Yeah, exactly. The point is that it's not so important, but we all agree that here, from a clinical and dermoscopic point of view, most probably we are dealing with a melanoma. Okay, so this is a melanoma which was not clearly melanoma for the pathologist, and therefore he used the term severely dysplastic nevus. So now that we know that we are dealing with a melanoma in situ, then we can decide whatever we like. I mean, if the patient is very worried about this lesion, why not offering him a re-excision? Then everybody will be more relaxed. Or if you consider that, of course, melanoma in situ will never kill anybody, you can even leave it alone. But in general, here I find that the question is very clear. We have a melanoma inside in front of us, although for the pathologist it was not clear enough. Okay.
By the
Now,
way,
last
question.
yes.
One question. Ever since WHO suggested that severely dysplastic nevi and melanoma in situ should be treated in the same way, have you gotten
Yeah.
a very high rise on the diagnosis of severely dysplastic nevi?
Yeah.
It's like,
It's another story that maybe we can talk about. It's a complete disaster now.
yes. It has doubled, tripled.
Yeah. It's a complete disaster. Now let's close with an even more easy case. This is a 15-year-old boy, and this is a slightly palpable lesion located on the leg. And dermoscopically, you have this morphology with dotted vessels mainly visible at the periphery, a little bit of white lines in the center. So the lesion was excised with the provisional diagnosis of Spitz nevus, and this was called atypical Spitz tumor. Okay?
Mm-hmm.
So now, taking everything into consideration from a diagnostic point of view, is this more obviously a Spitz nevus or a melanoma? What do you think?
Spitz.
Spitz, clearly, no? So she is 15. The lesion looks like a small papule. It's looking dermoscopically in line with this diagnosis. Most probably, this is just an ugly-looking Spitz nevus. Okay, so now we can take our decision what to do. Should we re-excise, yes or no? Nisa, are you going to re-excise?
Yeah. Actually, JP, I re-excise if the pathology report came as atypical Spitz nevus. So maybe 3 millimeter more, I'm gonna excise it.
Okay. You, Emilio?
And complete it to 5 millimeter.
Yeah. You, Emilio?
If the excision was very marginal, then yes, I would re-excise, because I think that Spitz nevi, although they are benign, they have a tendency sometimes to behave, so to recur. If you don't excise them adequately, they might recur without any significance, but it might happen and put you into trouble. So I would be rather prone
to re-excise. Costantino?
Re-excise for sure.
Okay. So everybody is for re-excision, but not because we think that this must be done for the chance that this is a melanoma, but only because you think that from a medical legal issue is more valid, right?
And also,
I
Exactly.
mean, come on. This is the only reason why we are going to re-excise in a 15-year-old boy a lesion like this, because this is, you know what I mean? It's just for a medical legal issue.
How many cases of pediatric
Yeah.
have you had, Jeppy?
How many?
Cases of pediatric melanoma have you had in your career?
Well, let me tell you, maybe 5.
5. Emilio?
no, less. Well, pediatric, what do you mean?
Well, lower than 18. Let's go lower than 18.
18, 2. If you ask me lower than 12, 0.
Lower than 12, maybe just 1. Yeah.
Lower than 12, I have 3.
Yeah.
All schizoid.
Yeah, which
And
is a
that's the
matter
point.
of.
And
That
that's
was
the
my next
point.
question.
And that's the point.
That was my next question.
Yeah.
How many of them were schizoid?
Yeah.
So I will, again, case by case, as you said, Jeppy, but also morphology plays a role. If it was a totally banal spitz and it came back in pathology as a typical spitz tumor, whatever. But this was ugly looking in pathology as well. So in morphology as well. So definitely, I would go definitely for excision on this one. This ugly looking spitz, you know?
Yeah. The point is this. I have, let's say nowadays, I'm becoming an old guy. I'm still not an old guy, but I'm becoming an old guy.
No, for sure.
I
No.
can start expressing myself in a more free way, not politically correct. You know? I strongly believe that none of the schizoid melanomas diagnosed in pre-puberal children are really malignant. None of them. Yeah. Because it's none of them. Because it's simply impossible from a logical point of view, from a reasonable point of view, that a small child is 2 times unlucky. First, because he is suffering from a very rare disease, which is melanoma, and secondly, from a melanoma which is mimicking a Spitz nevus. This is nearly impossible. The only patients below the age of 18 that I experienced with a melanoma which eventually gave metastasis and killed the patient were melanomas were not mimicking Spitz. They were just conventional melanomas, conventional.
Or melanomas in congenital nevi, or
melanomas in congenital nevi, or very aggressive melanomas, but not mimicking a Spitz. Okay, so whenever I have a diagnosis of Spitzoid melanoma in a child, I'm okay. I know we have to re-excise, but I'm pretty sure that this is a wrong diagnosis.
Okay, will you do a sentinel lymph node biopsy on that child?
Never, ever, ever, ever. Never, ever.
Never.
But you remember that I just told you a couple of weeks ago that we were together in the ADO, and I was on stage after your talk, and I told you that the new theory is that all schizoid melanomas are in fact benign.
You said the same.
Yes, of course. How can you forget? It's 2 weeks ago.
No, but you said the same also in this particular technical detail. Yeah.
What do you think the possibility is of this 15-year-old tumor for recurring metastasizing? I think this should be communicated to the patient, its parents, before going ahead with re-excision of the scar. Of course, but I have to share with you the following. We often discuss about atypical Spitz tumors. We like the topic. We have worked a lot on it. It's fascinating and so on. But in terms of communicating with the patients and the parents, this is one of the most difficult scenarios. Because, I mean, come on, what can you answer to the question? How can you explain to a mother or to the patient itself? Because sometimes the patient is 15, 16, 17, 18, so you speak with the patient anyhow. How can you explain clearly what this tumor is unless you do exaggerations? If you do exaggerations, maybe you can communicate an understandable message. But if you don't do exaggerations and you stick on the evidence, it's extremely confusing message.
Yeah, it's a mess. It's different. It's difficult. But in order to summarize, maybe we need to summarize this. What we have to bring home from these three cases that I showed you. There are instances in which we don't know what to do, either because the pathology comes back as an intermediate lesion, dysplastic, atypical melanocytoma, atypical speech tumor, and so on and so on. In these cases, the only way to make a decision is to take the responsibility of the final diagnosis. Okay, you have to put together the clinical, dermoscopy, histopathology, and then you have to ask yourself, what I think is this lesion? Is it more on the side of a melanoma or more on the side of a nevus? And then decide according to what you think about the final diagnosis. Okay.
Absolutely. Is it possible to use topical imiquimod as an adjuvant instead of re-excision if clinically the excision margins were 2 millimeters in case of lentigo maligna? Of course, yes. We don't speak about lentigo maligna merits a separate discussion. I think we did it or not. I'm not so sure, but it's definitely a good idea. And no, in my view, we have to move on. Sebastian, to show us something.
Sebi.
Maybe Sebi before Nisa. Yes, you do. Very good. Very nice.
Wonderful.
Nisa, are you ready?
Yeah, I'm ready.
Let's go. By the way, before you start, quotes, guys, quotes.
We forget it.
We have one suggested. Keep in mind that if you don't cut enough, melanoma could be back. That's one. Then another one that I said once, but I don't remember if I ever put it as a quote. Relapse of a BCC is not the end of the world. Do you like it?
Yeah.
It's not the end of the
Very
world.
nice. Very nice.
Okay, we will put it in the voting. Mostly margins matter is another one. And keep sending your proposals. And Nisa, please go with your cases.
Thank you. Can you see my screen?
Yes, we can.
Yeah. Yeah. For the first case, this is not a question. This is a clear-cut melanoma, right, guys? Because it's an ugly duckling and the features are all consistent with melanoma. But histopathology report came as dysplastic nevus with severe atypia, which is not an acceptable diagnosis here. Here you can re-excise it to 5 millimeter margins or take a second opinion, because I talked with my pathologist and she said that no, this is not a melanoma. This is a dysplastic nevus with severe atypia. I cannot write the report as melanoma in situ. So we prefer here to enlarge the margins.
Yeah.
Another case, This lesion appeared recently, and the patient was 45 years old, male, and histopathologic reports again came as dysplastic nevus with severe atypia. So this is questionable. It could be a dysplastic nevus with severe atypia or melanoma in situ again. Again, we prefer here to enlarge the margins because there was subtle gray here as well. So there could be a possibility of being a micro-invasion. And we complete the margins to 5 millimeter and take second and third opinions here because this lesion was a part of a study as well. And Harold and Simon Clark from Australia said directly to melanoma in situ for this case. So I think for lesions coming as dysplastic nevus with severe atypia, if you have strong suspicion and if you believe that it's a melanoma, you can re-excise it. You can enlarge the margins. You are also in the middle and you are not so sure about it. You just excise it with some little suspicions. Maybe you can leave it there. Or again, you can take a second or third opinion. But I think this lesion really is very suspicious. And the previous one was a clear-cut melanoma. So these diagnoses are not acceptable. I think this depends on the dermatoscopy, the clinic, and the age of the patients. And you can decide according to all these parameters. Agree, guys?
Absolutely.
Very good.
Absolutely.
Okay. And this is a patient. This patient is an unlucky patient because he was 43 years old when his melanoma was diagnosed, and breast of thickness was 1.5 millimeter. And surgery was performed. And here you see the margins, lateral borders 0.7 millimeter, deep borders 2.8 millimeter. And the surgeon thought that he made enough large excision and they didn't make re-excision with these margins. And 6 months after surgery, you see there's a scar tissue here and there are 1, 2, 3, 4, and 5 pigmented lesions appeared on the scar. So this was metastatic melanoma. Maybe it will show some metastasis because the breast of thickness is 1.5 millimeter. But I think the margins are not so good here and re-excision should be done in this case. Don't you think
Yeah, of course.
the same advice?
Absolutely.
Yeah.
And one thing that I want to highlight is that although it has been taken off the guidelines, I strongly believe that mitosis do play a role. It shows the biological activity of the tumor. This had like 11 mitosis. It shows that it's an aggressive tumor, you know? It's something to take into consideration. I don't know what your experience is with mitosis, guys.
Yeah, I completely agree with you. The high mitotic index is very, I think, affecting also the prognosis. But in the latest NCCN guidelines, they remove the number of mitoses from the pathology.
I know it's removed, but like instinctively, I can tell you that it shows to the activity of the tumor. I don't know.
Yeah,
sure. And another point is also the location, the location of the
location, especially for the acral site, because the surgery here is very hard for the surgeons as well. And here you see the melanoma. It's already invasive one, and you see the pathology report, breast of thickness 4 millimeter. But the margins again are very close here. As you see, deep margins 0.8 millimeter for a breast of thickness of 4 millimeter. It should be enlarged again. Here is the scar tissue. They didn't re-excise it. And 1 year later, you see here very close to the surgical margins. This was an epidermotropic melanoma metastasis, but eventually it will show metastasis because breast of thickness is 4 millimeter is too much. But I think margins are very important. Okay, now the question comes. Is this an high risk or low risk tumor?
High.
Ulcerative BCC.
High.
Yeah, BCC.
High risk, infiltrative.
Infiltrative, yeah. So I think we don't have a look at the poll because it's a very clear-cut basal cell carcinoma. When we have alteration, especially it's more than half of the lesion, it's most likely, the diagnosis is most likely an infiltrative basal cell carcinoma. And so here you don't need to take a biopsy. You can excise it directly. Don't you think the same, guys?
Well,
For
depends.
6 millimeter margins.
If you have the availability for MOS, here there is an indication for MOS. And in order to do MOS, you need a confirmation first. So
yeah, but we don't have MOS. So
okay,
we're going to make...
But
so
yeah, I
we
agree
excise it
completely.
with...
I agree completely.
Yeah.
You can go immediately with 5 millimeter.
5 millimeters. I agree.
Yeah. We did the same, and it was okay. And another case, is this a high risk basal cell carcinoma or low risk?
Low.
It has the May globules. It has the May.
I don't know if they're May globules or keratin, but quite a lot of keratin.
Yeah. There was a lot of May globules here, and we performed a study, and aggregated black-brown clots are also a feature of micronodular basal cell carcinoma. And so we guessed that this is a micronodular basal cell carcinoma, and again, re-excise it, directly excise it without sending the histopathology with 5 millimeter margins. And histopathology was micronodular BCC and with clear surgical margins. So you can get some clues from the dermatoscopic view and excise it directly with the offered margins. So there is a tiny lesion. Is this a high risk or low risk tumor, basal cell carcinoma? It's a small one.
Risk.
High risk.
High risk for sure. Again, we have a big ulceration for such a small lesion and white structureless periphery. So this was an infiltrative basal cell carcinoma. Again, we excise it directly with 5 millimeter margins. And here I'm going to show you, this is for sure an high-risk basal cell carcinoma. And clinical impression also gives that it's an infiltrative basal cell carcinoma. And this was my borders according to dermatoscopy. And here you can see the borders, plastic surgery, performed the surgery. Lateral borders were okay, but deep borders, I cannot do for that because plastic surgery do it. And it was a bit close, but we didn't re-excise it. And I'm following up the patient with dermatoscopy.
The point is that the deep margins are usually not, I mean, on this particular anatomic location, you are immediately on the bone, you know?
Yeah.
On the
cartilage.
The cartilage.
Yeah. So it's
extremely
difficult to get very significant deep margin.
Yeah, but lateral borders are very good, isn't it?
Yeah.
For the report. 3.4 millimeter.
Good.
And this is my last question. Is this a high risk or low risk basal cell carcinoma?
Difficult to say. I mean, I don't know the results of your study concerning these small globules, but in general, when I see pigment in a BCC, I'm prone to think about low risk.
That's definitely true. Definitely true, except of micronodular. Micronodular might be pigmented sometimes, but the other three not.
And the other thing is the multiple arborizing vessels in the periphery. I think this is an indication for high risk.
Yeah, great. I think in our study we also detect that when some vessels are out of focus, they are blurred. This is also a sign for invasion. So here, when we look at these arborizing vessels, branch vessels, some are very bright, but some are not very well focused. And the tumor islands, when they are not, we cannot see the margins clearly. They are located in the deeper parts. So this was an infiltrative basal cell carcinoma, this case. And according to our study, we didn't take a biopsy here. And again, we delineate the borders. Again, histopathology was very good at the periphery, and the deeper margins was not so bad, but you can get some clues from the lesions. When the vessels are out of focus, they are blurred. When the tumor islands, pigmented tumor islands are blurred, you cannot see the margins clearly. You can guess that tumor islands are located in the deeper parts, and this is most likely an infiltrative basal cell carcinoma as well.
Anna
And
Maria
here
saying something
you see
interesting.
the vessels.
Anna Maria is saying
For
something-
example, this is a very blurred vessels, don't you think? It's going in the deeper part.
Yeah. Yeah.
Some are bright, but some are really very blurred. And the dermatoscopes was very professional with camera. So with pressure, without pressure, with all sides, we try to capture the vessels, vessel morphology. So I think this was a good clue. When the vessels are blurred or out of focus, they generally indicate the infiltration of the tumor.
Yeah.
Wonderful, fantastic. There are a couple of questions. First, related to BCC. In some high-risk BCC, if there is no available MOS, you can excise with 5 mm margin and delay the closure after having the confirmation of clear or acceptable margin. Of course, first of all, this is the so-called slow MOS, but again, it depends on how the histopathologic specimen will be treated. So in the MOS technique, there is a different way of examining the margin with a horizontal sections that examine the entire margin, unlike the classic histopathology. But anyhow, even the classic histopathology is better than nothing, obviously, before closure. Another question is those histopathologic margins were from vertical rather than horizontal sections. That's why MOS is the gold. Yeah, exactly. That's what I just said. Very good. Then the other two are for melanoma. How much should be the lateral deep distance from tumor in the pathology report for malignant melanoma? We said many times that the margins are clinical, so we have to make sure that we have the 0.5 or 1 millimeter or 2 millimeter margins depending on the melanoma stage. Concerning the deep one, we said it at the beginning, it has to be up to the subcutaneous fat for melanoma in situ and up to the fascia of the underlying muscle for invasive melanoma. Another question which is interesting is by Giuseppe, saying that if you have a compound lesion, not purely junctional, and you think it's malignant, you excise it, and the report comes back as severe dysplasia, then what do? I mean, only the excision, because the concept is that if it is a melanoma, it's not the melanoma in situ, but it's an invasive melanoma. Therefore, what do? The excision or send the lymph node biopsy also? That's an interesting question.
A very interesting question. I think that the most important is communication with the pathologist. Where is the most severe atypia? Because it can be found either on the dermal component or the junctional component. If it's in the junctional component, a wider excision is enough. If it is in the dermal component, then you need to ask yourself and the pathologist if it was a melanoma, what would be the Breslow, and act according to that. But I think there also morphology will guide you, like instinctive, but also morphology. And second opinion. Second opinion can also work. I don't know what you guys do.
But yeah, of course. But in general, let's say that, of course, we can do, from a clinical point of view, a re-excision, even if the report says dysplastic nevus. But performing a sentinel lymph node biopsy without a change of the histopathologic report probably is not the case.
Absolutely.
Would you prescribe adjuvant Aldara in BCC or lentigo maligna excised with narrow margin? Of course, yes.
Of course.
And that's it, I think.
Yeah.
We have a couple of suggestions for quotes. I like very much, in margin, there is no cancer. In margin, there is no cancer.
Margin, there is no cancer. Yes, but the big enough size to save cutting twice is very nice as well.
All right, okay, we will have a good competition for the quotes. Nice. Konstantinos, you go, and then I have to show you something, but first you go with your cases.
Absolutely. So I also have prepared some cases to spark conversation, although it's quite late already. So I think that we won't go deeply into discussion. So this is a 55-year-old male, comes with this lesion, and this is the dermoscopy. What do you think that it is, Sebi? Is it a melanoma in situ? Is it an invasive melanoma? Low risk basal cell, high risk basal cell, high differentiation SC, low differentiation SC. Invasive melanoma, the vast majority of people. And indeed, this came back as a 0.4 millimeter invasive melanoma with extensive regression. And the question here is, so Sebi, if you can put the next question. And I should have another question that I will ask to you guys.
So,
Yeah, this is a very difficult topic.
which was the breast flow? 0 point?
0.4 with extensive regression.
Extensive regression.
Extensive regression. And the pathologist was also kind enough to measure the regression. It was up to 0.6 millimeters deeper. So the regression reached up to 0.6 millimeters, up to 1 in essence. The question is, the next question, do you do a sentinel lymph node biopsy here, yes or no?
No.
No.
Yes.
Well,
Yes, I will do.
You do sentinel node biopsy. Yeah.
Debbie?
Extensive regression. It's worrisome.
Well, extensive regret. I mean, this is a very long story, and it's very difficult to assess in a few minutes we have. But in a case like this, I would take this information into consideration because the lesion is quite large. I always take two parameters together: extensive regression plus clinical diameter. If the clinical diameter is very significant, then I start to think that probably regression might be a confounder of the real Breslov thickness of this lesion.
Yeah.
We actually went,
Konstantinos, how was the PET CT? Was there a metastasis already?
no, on staging, he had nothing, but we decided to do a sentinel lymph node biopsy, and it was positive.
Positive?
Yes.
No, come on. Wow.
Yes.
By the way, it is, we have to say that what you said.
Extensive regression is very worrisome.
Yeah.
Always worrisome.
Yeah. So what we discuss now is officially recommended. So if you have extensive regression, theoretically, although the breast flow is does not justify sentinel lymph node biopsy, you might offer it because of the extensive regression. Yeah.
Yes. But on the new version of the NCCN guidelines, it has been taken out. There is no regression in the criteria. If you look at them,
there was anyhow not the regression in the criteria. It was a sub note that in case of extensive regression, you might consider.
Exactly. So on the sub note, on the previous version, it was there. On the new version of the April, it's not there. The regression.
It's not there at all, eh?
Yeah, it's not there at all.
Yeah. Okay.
But this was done like before the update. So. Another case, scalp, you can see extensive sandamas, you can see the signs from the cryotherapy, from the multiple treatments, etc. And this is this lesion. Is this a high differentiation squamous cell carcinoma or a low differentiation squamous cell carcinoma?
High.
High, most people answered it correctly. We can see the white circles, so it's a high differentiation squamous cell carcinoma. The cancer has retained its ability to produce keratin. And now the next question. Sebi? The lesion was excised with 1 millimeter histopathological margins. What is the management? Re-excise or observe? I think this is the main question here. Most people would re-excise. Nisa?
For sure, excision.
For sure, excision.
Re-excision.
So
Emilios?
1 millimeter.
1 millimeter clear margin.
There is clear margin.
Clear margin.
Margin.
Well differentiated SCC.
Well differentiated SCC.
Well, clear margin.
Not so sure.
Why not observe?
Observe or a MICUI mode in the area, or yeah. I'm not so sure.
Mode, yeah. Mode is possible, or even FODX can be given.
Yeah, also.
Yes, I agree. Absolutely agreed. Now, patient with atypical mole syndrome, you can see, and we're talking about this tiny lesion over here, which dermoscopically was like this. New lesion, patient with a history of melanoma. Okay, vast majority went with melanoma in situ. And for the next question, Sebi, instead of 1 millimeter, keep in mind that this may be 3 millimeters. 3 millimeters. So it was excised with 3 millimeter histopathological margins. What do we do?
So melanoma in situ was the diagnosis.
Melanoma in situ. Melanoma in situ.
Overdiagnosis.
You think that this is not a melanoma?
No. I think that this might be melanoma, but this is the prototype of what they criticize as overdiagnosis. You know, this small melanoma that.
Yeah, it's 2 millimeter melanoma, but morphologically.
No, makes sense.
So majority voted for 5 millimeter re-excision. Do you agree? Do you agree? I mean, if I have 3 millimeter already,
3 millimeter.
I would say, come on, leave it alone.
I also left it alone. It was 3 millimeters. For this one, it was 3 millimeters.
So if it's 3 millimeter, I leave it alone. If it's 1 or 2 millimeter, maybe, why not? Yeah.
Next question. This is a 60-year-old lady with this papule on the nose, and this is the dermoscopy. What's the diagnosis? Well, I think the answer, the question here is low or high risk BCC. High risk BCC says the majority, exactly because of the May globules that we can see. And sorry, Sebi, you can put the next question. 1 millimeter histopathological margins. Histopathological margins.
Yeah. So clear margin already.
Clear margins already. Micronodular in histopathology. Most go with 5 millimeter margins. Some, a lot, go with 10 millimeter margins. 19%. I mean, it makes sense. And other, I guess, Aldara, I think that all options here are viable. JP, what would you do?
Observe.
Observe. Emilios?
Sorry, my friend, I'm preparing the quote.
I'm so sorry.
So I agree with JP.
I agree with JP. I like it. Nisa?
I think I will re-excise it a bit, maybe complete to 5 millimeter, because nose is a risky area. And when there is relapse, there can be some disfigurement on the nose, and this is a lady. So it's better to be on the safe side here, from my point of view.
I like it. I like it. And final question. This is a 41-year-old lady with this new lesion on the cheek.
Miss.
Miss. Agreed. And okay, melanoma in situ, 90%. And now the difficult question, cosmetically sensitive area. 41-year-old lady. Sebi, if you can put the next question. And you have 1 millimeter margin. Lendigo maligna, melanoma in situ. 58% go with re-excision with 5 millimeter margins, 10% with mere observation, and 25% with other. And I think this is a very interesting point for conversation in terms that
Yeah.
this is a young lady with a lentigo maligna. Of course, Aldara is an absolutely viable lesion, but she has 40 years for her to relapse. It's like it's a long period. But also, it's cosmetically very sensitive. Nisa, what would you do?
Very difficult.
It's a very
Hard
difficult.
to answer. Yeah.
It's a very difficult scenario.
Yeah.
I would say Aldara for sure.
Aldara for sure.
Imiquimod for sure, independently from the re-excision. So even though I decide for re-excision, I do anyhow imiquimod afterwards. But it's very tough. I agree. She's too young to be, let's say, less aggressive. So probably a re-excision could be the right choice. I mean, a re-excision which would be cosmetically still acceptable, so direct closure.
What's the scenario? The lateral margin was involved.
No. So this is a scenario of a 41-year-old lady with a lentigo maligna with 1 millimeter clear margin.
Clear margin.
Clear margin, 1 millimeter.
Okay. No, then I would select imiquimod without re-excision.
Without re-excision.
Yeah.
But the question that I pose is that she's very young. So she has a very long time for her to relapse,
Yeah, but she will not. With imiquimod, she will not relapse.
I love the certainty, my friend.
You trust imiquimod 100%.
Well, as the study showed, not 100, but 95. So 95 is quite a lot.
Yeah.
Yeah.
In 5-year follow-up, but lentigo maligna is a very slow-growing melanoma.
Yeah.
So,
and also relapse of a lentigo maligna is not the end of the world.
Okay, another question: Can a melanoma in situ relapse as an invasive melanoma?
That's an interesting question.
It could be. I had a recent case, unfortunately.
Yeah.
This is the fear.
Yeah. Which puts in question also the initial diagnosis, maybe.
Yeah. Ragazzi.
Very good.
Ragazzi, what do you have to say, Emilio?
Many things. The first is that I would like to shortly remind you this wonderful toolkit, let's say, that Canfield offers with so many products, and to remind you that we can insert the data of our patients, make the total body imaging either 3D or 2D, and then add on it dermoscopy, but also confocal if available. And in addition to this, a lot of functions based on artificial intelligence. First, the automated detection of lesions, then, of course, the automated tracking and change analysis in the sequential visits, and finally, the automated score assessment of the dermatoscopic images. All these functions work both on the 3D version, the so-called Vectra machine. You can see here the automatic detection of the lesions and the automatic detection of the changes, very nicely highlighted. But all these functions work also with the Intel Studio, which is the 2D version. And then you have all of them working also there, the automatic detection, but also the automatic assessment of changes, as you can see in this slide. So that was the first thing that I wanted to share with you. The second thing that I want to share with you is the gifts that we have today from our dear Penelope, which are very nice. And then we will do the Kahoot, which is very easy today because you accused me last week of including very tough cases. So let's see first the gifts from Penelope, starting always with a gift for Nisa. This plantar lesion bothered me a lot. I'm 37-year-old female with insulin-dependent diabetes. You see the clinical aspect. You see quite interesting dermoscopy, featureful somehow, a lot of vessels. I have already been treated by cryotherapy several times, and it always comes back. Come on. Would you have a more radical method of getting rid of it, please? And what diagnosis do you suspect? What do you think, guys?
Misa, you're on mute.
Oroma.
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 Why not? Anything more pessimistic? No, no. You are in a good, in an
Oroma.
optimistic place.
We're in a good mood. We're in a good mood.
Very good, very good.
Emilio, what's that? Collagenoma. Okay.
Oh, collagenoma. I mean, what's that, guys? Also called solitary sclerotic fibroma, rare benign soft tissue tumor, can appear as part of Cowden syndrome, more commonly found on face, neck, and upper lips. Rarely reported dermatoscopic features, homogeneous white background with peripheral arborizing vessels. Unique case for UNISA today by Penelope. Konstantinos, for you, we have a dermatoscopic challenge on the hand of an 84-year-old man for 6 months. What can it be? A lot of white color.
The hand.
Carcinosis cutis.
I think something with calcium. Yeah, calcinosis.
Iloma-
Carcinosis cutis.
Yes, more or less. More or
Oval,
less.
oval.
More or less. Yes, glutitophus.
We are close.
Very close, very close. Very few publications about dermoscopy, rounded, chalky, white structures associated with a linear, irregular, branched out of focus vessels, of course. Then for JEPI today, we have this pigmented lesion, 74-year-old, palpable on the shoulder, recent change of aspect from a previous pigmented lesion that appeared 10 years ago. And that's what you get with dermoscopy.
Ah,
Seb K.
Like it.
Seborrheic keratosis. Wonderful.
Seborrheic keratosis only.
Well, what's that?
Yeah,
lower
Yeah.
part.
Bowens.
yeah,
Bowens.
yeah. What did you say?
I think Bowens.
Bowens?
Bowens
Because
is
I remember this case from Facebook, dermatoscopy blog.
you know
I think
it
she
from-
previously asked
from
this.
Facebook. Wow, because then it would be very impressive if you said Bowens, which, by the way, is the case. Pigmented
Yeah,
Bowens.
I remember this case.
yeah.
It was unique.
Yeah.
So everything is Bowens.
I'm not
Everything
so
is
good. I'm
Bowens.
not so good to guess the diagnosis.
Everything is
Tired.
Bowens. Yeah.
Tired brown globules at the periphery, sharp demarcation, funny pattern made of brown tired globules wearing a whitish halo.
Wonderful.
Fantastic. And then for me, without any skin cancer history, has been seen this clavicular lesion change in recent weeks. And this is what you get. I have to tell you that when I saw it instinctively, I said BCC.
Me
Then I
too.
started. Huh?
Because of the dots, it looks like
Yeah,
BCC.
because of the dots here, some vessels, I instinctively said BCC, but then this was very unusual for a basal cell carcinoma. So yeah, I was not so sure what else it could be. Of course, lentiginous
Melanoma? Is this
surrounding.
melanoma? What's that?
Of course, then when you start thinking about strange scenario, then melanoma becomes a possibility. Eventually,
Oh,
here you can see the non-polarized light with quite evident milia-like cysts, by the way. So eventually, this is a collision, a nice collision tumor of basal cell carcinoma with seborrheic keratosis.
beautiful.
Very
Very
nice.
nice.
And really
Very
collision.
nice.
I mean, really collision. It's
Yeah.
just the one on top of the other. And of course, we can see the clues for both of these diagnoses. And finally, for the nicest of coordinators, SEBI, we have this 34-year-old woman. Her GP cut this lesion some time ago, and now she's worried because the pigmentation is coming back. And this is what you see dermatoscopically.
Recurrent nevus, yeah.
That's a nice example of a recurrent nevus that tries to look like a spitz. Recurrent nevus is trying to look like a spitz. That's his purpose in life. I want to be a spitz. Yeah. Yes, yes, yes. Wonderful, fantastic. So recurrent nevus is, of course, the diagnosis here. Wonderful cases as always, Penelope. And now let's go to the Kahoot. I'm really curious to see what's going to happen with the quote of the week, because we have very nice proposals today. And then I have a very easy Kahoot, so be prepared. You have to be fast in order to win today. Come on, come on, come on, come on. Okay, start. Get ready to join. I forgot. No, I will wait a moment. No, I will do it in a moment.
What?
I forgot to share the sound, but I will do it in a moment. It's not a problem.
No, we can hear the sound.
You can hear the sound.
Yeah.
Fine. Fine.
Wonderful. You know that we got very nice suggestions for the next episodes.
Yes.
Lesions, extrafacial lentigo, palmoplantar lesions, small diameter melanoma, Spitz nevi,
Nevi again.
surgery. Yeah.
No matter how many times you do speech, it's never enough.
A lot of people appeared this time. Okay, let's start, and many more will appear for sure in a moment. Episode 15, guys, by the way.
Yes.
Wow.
Paul, first quote of the week for today. I found 5 options. Imagine there is no cancer. Big enough slice to save cutting twice. Mostly margins matter. Keep in mind that if you don't cut enough, melanoma could be back. Relapse of BCC is not the end of the world.
Really nice quotes.
Yes.
Yeah. Wonderful. I vote for big enough slice to save cutting twice.
Wow.
We have a tie, an absolute
First
tie.
time.
Unbelievable.
First time. So,
Unbelievable.
guys, we do like this. Now we 4 vote, and if it's 2-2, then Sebastiano decides which is the winner. Okay. So, Nisa, vote first, but you have to vote
First one.
between the 2. Okay, the first one. Konstantinos,
The second one.
the second one. Jeppy,
Big enough.
and I vote the first one
Yes.
because I want to sing it also. So Sebastiano has to decide which is the quote of the week. Imagine there is no cancer or big enough slice to save cutting twice.
The first one.
The first one, okay. So we have a winner. Sebastiano, come on, let's sing together. Imagine there's no
There's no
cancer.
cancer.
Okay, so now this brings us to the first case for today, which is this one. That's the clinical. This is dermoscopy. Ready to play? Ready to play? Let's play. Quiz. Diagnosis. Do you think that this is a nevus, dermatofibroma, basal cell carcinoma, seborrheic keratosis, pigmented Bowens, or melanoma?
Sta bene.
And the correct answer is dermatofibroma, found by 54 people. Congratulations. That was not so easy, but it was feasible. Yeah.
Yes.
Okay. And we have Rats, Dermi, and Alexandra in the first 3 positions, which brings us to case number 2. That's the case number 2. That's the clinical. This is dermoscopy, a little bit blurred, unfortunately, which annoys me a lot because the image is so nice in reality.
But
Anyhow,
it's feasible. It's feasible.
that's the same for everybody. This is a collision of nevus and melanoma, seborrheic keratosis and BCC, seborrheic keratosis and dermatofibroma, nevus and lichen sclerosus.
Sta bene, sta bene, sta bene. I vote for Nivus plus.
Yes. Seborrheic keratosis
Bravo,
plus
bravo.
BCC. Very well. Which brings rats still in
Rats.
the first position.
Wow,
Dermatolog girl.
very
That's Laura,
Very
no?
close.
No, in the second place. Go, Laura.
And oops in the third place. And now, case number 3, that's the clinical. This is dermoscopy. And here comes the question, true or false? This is simply a nevus.
Piri-biri-bip, piri-bip, piri-bip, pip, piri-biri-bip, pip, 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 pip.
By the way, if I have one nightmare in cutaneous oncology, it's the bloody nevoid melanomas.
Yeah.
Yeah,
It's like
actually.
the horror.
But this is not the case here. This was simply a nevus. That was simply a
Yes.
nevus. That was simply a nevus. And what happens is that dermatolog girl is in the first place, Caramia in the second, and Laura B in the third. Laura is playing with 2 accounts just to make
Yeah.
sure.
This time, Laura. Go, Laura.
Okay, case number 4. That's the clinical. This is dermoscopy. And
Yes.
here is the question. What's this? Is this a traumatized nevus, melanoma, BCC, lymphangioma, Kaposi sarcoma, or LPLK?
Laura, this is so easy for you.
I vote for psoriasis.
I vote for lymphoma. Now, the question is, what is the subtype?
Superficial.
Superficial. Superficial for sure.
Superficial and nodular on the top, I think.
Basal cell carcinoma, 74 correct answers. Let's see what's happening. Dermatolog is still in the first place, followed by Panos and Caramia.
Cara
Be
mia,
careful.
cara mia.
And everything depends on this
Laura, go, Laura.
vision here. That's the clinical. This is dermoscopy. Shh. Shh. Don't speak. Don't speak.
Don't speak. Do, 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 do.
This is simply a nevus. True or false?
How old is the patient?
No help.
By the way, guys, this week, a patient came in the hospital, and I went in to see him, and he said, "Hey, I know you. I've seen you in Dermoscopy Happy Hour." He was the patient. The
Oh, I
patient.
can't believe it. I can't believe it.
I was shocked because he had a diagnostic melanoma, and he was looking everything that there is regarding melanoma, and he was like, "Hey, I've seen you in Dermoscopy Happy Hour."
So that was simply a
True,
nevus.
true,
Let's see what
true,
happens.
true.
Third place goes to Caramia.
Cara
Yeah.
mia.
Second place goes to Panos,
Vamos.
which means that very possibly first place goes to
Dermatolo girl.
Bravo.
Laura.
Bene, 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 bene.
Bravo, bravo to all of them, of course, to all of them, for sure.
Grande, grande.
And
She promised me she will be in the podium.
yes, let's see if we have Laura. Let's see if we have Laura with us. So but we have to say, by the way, that next Sunday, we are not here because it's the Greek Eastern.
Ah, okay.
Orthodox.
We have a
Orthodox.
break. The Orthodox Eastern, yeah, not the Greek, the Orthodox Eastern. So we will be here again on Sunday, which is the date? I don't remember. Sunday the
12 to 12.
12th.
Hi guys.
Hey, Laura.
Hi.
Hi, Laura. Ciao.
Bravi, bravi.
Congratulations.
You were struggling a lot and
Yeah, not so
finally-
much actually. Emilios humbled me saying that this scout was so simple. Thank you so much.
But Fantastic,
Wonderful.
fantastic, Lara. Congratulations.
And
Thanks
thank
a
you.
lot for being here every
In
Sunday.
the end, Nisa, it was weeks.
Beautiful.
I'm a big fan of you, Laura.
Yeah, I know that. I give you a kiss.
Wonderful.
Wonderful.
Fantastic. Very nice moment. So thank you all.
Thank you,
Yes,
my
in 2
friends.
weeks.
Thank you. Thank you. So
Take
see
care.
you in 2 weeks.
2 weeks time.
Weeks.
Baci baci.
Gli abbracci.
Bye bye.
Bye.
Bye bye.